طيب بسم الله الرحمن الرحيم. We'll start for our second session for today. Welcome everybody again, and thank you again for the organizing committee and the scientific committee for this nice meeting for SOHO, Saudi Arabia. So our second session will be about MPNs. It's my pleasure to introduce our first speaker, Dr. Naseema Gangat. She's a professor of medicine and the division of the hematology at the Mayo Clinic at Minnesota. She's currently serves as the education chief, division of the hematology and the program director of the Advanced Hematology Fellowship Program. Dr. Gangat was, her previous work was, she had special interest in MPN and AML. She served before as the editor-in-chief for the American Society of Hematology News Daily. Dr. Gangat is well known for her interest in AML and MPN. Welcome, Dr. Gangat. And the floor is yours, please.
It's a distinct pleasure to be here. This is my first time in Riyadh, so I'm deeply honored to be speaking to this audience, and I'm really looking forward to interacting with all of you during the breaks time. So the topic today that I'm going to start off with is the mutational landscape of myeloproliferative neoplasm and its therapeutic applications. So here are a few of my disclosures. And this is the layout of my talk. We'll go through the diagnostic approach, which is fairly straightforward, going through both the ICC and the WHO, but pretty much there is synchrony between the two classifications, prognostic assessments in the era of molecular genetics, and then going through some of the therapies and a very broad overview on therapies since in the interest of time. So I put in this slide to kind of give you a general landscape of where do the MPNs fit in. On the other end of the spectrum is AML, and then the MPNs kind of put in the middle of the slide, but there are several myeloproliferative neoplasms. This talk today will focus on the Philadelphia negative, which are hallmarked by the JAK2, CALR, and MPL mutations. So the three diseases that we're primarily going to talk about are essential thrombocythemia, polycythemia vera, and myelofibrosis. And then CML is a separate entity on its own, which will be covered later in the session. So just to kind of keep everybody up to speed, what are the main driver mutations? We all know about the JAK2 mutation, which was discovered 20 years ago this year, and that is prevalent in pretty much all the patients with polycythemia vera. The V617F is the most common mutation, followed by exon 12 mutations, which might be seen in PV patients. And then moving on to essential thrombocythemia and myelofibrosis, 2/3 of the patients harbor JAK2 mutations. And the ones who do not harbor JAK2 mutations, 1/4 of them have mutations in a gene called calreticulin, which is at the bottom of the slide, and then a very small fraction will have MPL mutations, which is mutations in the thrombopoietin receptor. And then there remains a small subset of patients, about 10%, that are negative for all the three mutations, which we call triple negative, not to be confused with triple negative breast cancer. So once we establish the diagnosis through molecular profiling as well as bone marrow biopsy in most of the patients, then we move on to what is prognosis like for these patients. Since these are chronic diseases, patients always like to know, am I going to live long enough? Am I going to develop acute leukemia? What's the risk of my diseases and become myelofibrosis, and what are the complications, the thrombotic complications in particular. So in this slide, we kind of go over all the three diseases in one slide. First set is the overall survival. So for both patients with ET and PV, they can expect long survival in the order of decades. For myelofibrosis, the survival is considerably shortened, a median survival of 5 years or less. And then the risk for leukemia for patients with ET and PV is in the less than 5%, whereas for myelofibrosis, it's about 10%. And then the risk for fibrotic transformation in ET-PV, about 15%, and thrombotic complications are seen in about a quarter of patients through the course of their disease. So an important point to highlight here, since it will tie in with my second presentation this morning, is age and survival. So younger patients are counterintuitively going to live longer because there are less competing risk factors for death in those patients. And so for patients below 40 years of age, the median survival is in the order of 3 to 4 decades for patients with ET and PV. And even for myelofibrosis, those patients can live a decade or two. As you go up on the age spectrum, then the survival becomes shorter for these patients. So now we'll walk through each of the MPNs, since it's a very broad topic that I'm covering this morning, the driving mutations, the other mutational profile, and then prognosis. So we'll walk through each of these diseases step by step. So in essential thrombocythemia, we have to realize this clinical trials and prospective data is hard to get through because of the long natural history. So the best data we have is actually long-term natural history studies. And this is from a study we conducted of over 1,000 patients with ET who were seen at the Mayo over decades. And as you can see, the driver mutation profile does not impact survival in ET. And the risk for fibrosis is higher for patients with MPL mutations and with calreticulin mutation, in particular, the type of CALR mutation, which is the type 1. And I will go through the types of CALR later in my lecture this morning. And the leukemic and survival is also not impacted by the driver mutation profile. So what about thrombosis? So that is the main complication experienced by patients with ET. So that is impacted by what kind of driver mutation the patient has. If they're JAK2 mutated, the thrombosis risk is the highest, as opposed to if they are MPL mutated, then calreticulin and then triple negative patients have the least thrombosis risk, and particularly that might be that these patients may not have true ET. Some of these cases could be mixed up with reactive thrombocytosis since they didn't harbor any genomic profile or they did not harbor particular bone marrow changes. So once we kind of know what the mutation-based risks for these patients are, we can recommend treatment accordingly. So now there is considerable interest in profiling patients beyond the driver mutations to look at the whole NGS panel. So when we looked at the NGS panel for these patients, we found that there are certain mutations that may be high risk in terms of disease transformation and particularly in terms of reduced survival. And those mutations in particular were the spliceosome mutations, SF3B1 and SRSF2 mutations. P53, as we all know, is present in very small percentage of patients with ET in the chronic phase of disease, but when it does occur, it is associated with increased leukemic transformation. And then U2AF1 and SF3B1 mutations, once again, are associated with increased risk of myelofibrosis. So how do we counsel our patients about treatment in ET? So yes, we do have the molecular data, but traditionally, these patients are classified as high or low risk based on their age and their thrombosis history, because the main complication for these patients is the risk for both arterial and venous thrombosis. And this was a very simplified version, age above 60, presence of thrombosis versus no presence of thrombosis, and then it was further refined over the years after the driver mutation information was known for patients with ET. And here, once again, I highlight that patients who've either had thrombosis or who are older, age greater than 60, would be high-risk patients. And those are the patients we would recommend cytoreductive therapy. And for the low-risk patients, particularly if they're young patients without thrombosis history, observation or aspirin alone may suffice. And then once again, we can further stratify these patients based on whether they have JAK2 present versus triple negative versus CALR present, and can decide on how much aspirin they need or whether they need just observation alone, because you could skip even aspirin therapy in a small subset of patients. And then just the presence of age above 60 doesn't mean that the patient needs to be on cytoreductive therapy. They can further be stratified and see if they have a JAK2 mutation, they're at high risk for thrombosis, so cytoreductive therapy may be indicated. And if they're JAK2 unmutated, then aspirin alone may suffice. And then there's more and more data that has emerged that the twice-daily aspirin for patients with ET is more beneficial based on a prospective study which was published not too long ago, because you want better control of reduction of the thromboxane levels. And ET patients have a higher platelet turnover compared to patients who don't have ET or MPN in general. And for the cytoreductive therapies, Hydrea is our main go-to therapy. There's more and more data for interferons building up, particularly for the younger patients. And then if patients have had venous thrombosis, they should be on lifelong anticoagulation, unless it was a provoked event where it was in the setting of a surgery and there was something clearly identifiable. And aspirin use in the presence of extreme thrombocytosis needs to be carefully monitored, particularly if they have any signs or symptoms suggestive of acquired von Willebrand syndrome. So moving on to polycythemia vera, these are sister diseases, both ET and PV, so it's kind of easy to go from one to the other. And for PV, once again, we talked about majority will have the JAK2 mutation. There's very limited amount, less than 1%, that is JAK2 negative PV, and we always have to question the diagnosis, especially if there's no other clonality that has been established. When you profile patients with PV, once again, you can see a number of mutations that can be present in these patients, and the question is, what kind of prognostic significance do these mutations have, especially in a newly diagnosed patient in chronic phase of the disease? So once again, looking at the context of additional mutations in PV, the presence of SRSF2 mutations has been shown to be deleterious in terms of reduced survival. So if a PV patient in chronic phase has SRSF2, and now more updated analyses suggest even ASXL and IDH mutations might be negative prognostic markers for these patients. So those patients have to be monitored more closely and more carefully compared to a patient who doesn't harbor any additional mutations. The treatment approach in PV actually mirrors ET, except that we would recommend phlebotomy to maintain hematocrit below 45. And the disease risk stratification for thrombosis is much simpler because you're either above 60 years of age or no prior thrombosis because there's no driver mutation, additional driver mutations present in PV. And in terms of treatments, similar treatments such as Hydrea, the use of interferon, particularly the long-acting preparation, the Ropeg interferon, is gaining more and more interest. Younger patients, especially female of childbearing potential, which I'll review in my next lecture this morning. Aspirin therapy is the cornerstone for both ET and PV, twice daily versus once daily, especially if there's no side effects associated with it. And then if the Hydrea and the interferon are not working, and if the patient is having more signs and symptoms suggestive of MF, then consideration to be given to use of JAK inhibitor therapy, such as ruxolitinib, which is approved treatment for PV, which are hydroxyurea resistant or intolerant. And now moving on to the most sinister myeloproliferative neoplasm, which is myelofibrosis in the spectrum of ET and PV. And once again, highlighting that survival for patients with MF is considerably shortened compared to ET and PV. There are many issues that these patients face, anemia, which may be transfusion dependent, splenomegaly, constitutional symptoms, and then risk for disease transformation, particularly transforming to acute leukemia, which is the worst form of AML. I know we heard a lot about AML in Dr. Esfield's lecture this morning, but blast phase MPN is a unique form of AML, an entity of its own, which is excluded from AML studies. There are several genetic abnormalities that are present in PMF patients in particular. A third will have cytogenetic abnormalities, which can be risk stratified. And then the majority of them, when you run an NGS profile, will have mutations, additional mutations, which are recurrent myeloid mutations. And those mutations can help inform prognosis for the patients, particularly if they have mutations in ASXL1, SRSF2, U2F1, and IDH. I do want to highlight here that in primary myelofibrosis, the presence of a type 1 CALR mutation is prognostically favorable. And this is very important information because if a patient has type 1 CALR mutation, they can expect to have survival in the order of a decade or longer, particularly if it is not accompanied by any other high-risk mutations. And that is why it is important to look at the reports. The type 1 CALR is the 52 base pair deletion, and the type 2 CALR is the 5 base pair insertion in exon 9 of the gene. And I think this is a very simple way of looking at prognosis for these patients. You can start with clinical variables, or you can start with genetics, depending on the setting you're in and the resources that are available. As I highlighted, the presence of the CALR mutation really protects the patient, and they can expect to have a longer life expectancy. And if it is accompanied by high molecular risk mutations, then you may be able to circumvent some of the adverse prognosis. And here is a prognostic calculator for MF patients, which is available online. And then the management really depends on what risk these patients are. For the high-risk patients, transplant is recommended, since none of the drugs available are curative in nature. And for the low-risk patients, you can simply observe them. And transplant is valuable for patients regardless of cytogenetic risk category or molecular risk category. And here I have listed the 4 JAK inhibitors that are approved in the US, and they can be used depending on the symptoms the patient is presenting with. And ruxolitinib is the most common one, which is available worldwide. And then this momelotinib was recently approved to help with anemia associated with MF. And I'll end the last treatment thing with the interest in CALR antibody-based therapy, which is a very exciting area which may have disease-modifying potential in MPN patients. And here are my take-home points. I highlighted all the mutations that are emerging, particularly the role for molecular profiling these patients. Allotransplant is the keystone, especially for high-risk MF. And then a consideration needs to be given to seeing what disease-modifying therapies are available in clinical trials. So thank you for your attention this morning.
Okay, thank you very much, Dr. Gangat. This is a very nice and comprehensive review. We know each disease requires lecture by itself alone. We may have time for 2 questions.
Yeah, can I?
Please go ahead, Dr. Naim.
Dr. Naseema, thank you very much for an elegant presentation. I just, one question, if you have, I'm here.
Right there, sorry, I couldn't see you with the lighting, yep.
Okay, so thanks for an elegant presentation. Just one question, for very high-risk patients for MPN or PV, or if they have this high-risk mutations like ASXL1 or SRSF2, and you would take them to, you said, to allotransplant. Would you use ruxolitinib first, or you can take them to transplant because of the very high risk upfront, or any cytoreduction to be done? Would that benefit in any case? It's just.
I think the treatment is symptom-based. So if the spleen is enlarged, yes, certainly Ruxo will have a role to optimize the spleen, but they don't necessarily need treatment just to debulk them. It depends on the situation for the patient. If you're transplanting just on genomics, it's usually associated with high-risk clinical features as well, right? So most of these treatments, patients will need some form of treatment. And I think the majority would have tried like JAK inhibitor therapy before getting to transplant.
Okay. So you do NGS for all newly diagnosed patients with MPN?
It is recommended, especially for MF, since the prognostication is all molecularly driven. For ET and PV, we are trying to incorporate that in routine practice as well, but it has yet to be made commonplace in the rest of the world. And it's hard to know what to make of the information if your patient has ET and PV. We don't want to act just on a genomic report, right? You want to put it in clinical context. So like you mentioned, it would be very unlikely that a patient with ASXL or SRSF2 is not going to have any clinical features of high-risk disease. So the majority would be patients who are treatment requiring. Okay?
Oh, thank you very much.
Okay, we have a question there. Please go ahead.
Where are we in terms of haplotype 46.1 testing in triple negative MPNs particularly? Now why I'm asking the question is because we did a study a year or 2 ago regarding 46.1 haplotype at Unified Medical C here in Riyadh, where we showed the association of 46.1 haplotype with ET and thrombosis. Could you please?
I think you raise a very good question. We haven't been routinely testing for the haplotype. It's not a clinical test that's available, but definitely in your patients that are triple negative, the whole goal is to investigate them as deeply as possible on a research basis. But at Mayo, we don't routinely test our patients for the JAK2 haplotype. But thank you for bringing that up to enlighten the rest of the audience.
Okay, thank you very much, Dr. Naseema, again for this nice review. And we're looking forward for your second lecture. Thank you.
Thank you. Thank you, everyone.
So our